project. They're both bright young stars who are R2s and are presenting to us about post-dural management of post-dural puncture headaches. And what prompted Alan to investigate this and look into it is the fact that he actually saw a post-dural puncture headache, managed it, and he actually said he had one. And as I said to him, he's had one, and there are probably more to come. We've all had them, and sometimes we've had them and we don't know we've had created them. So thank you very much for presenting to us, and we look forward to your presentation.
Okay, so when Alan and I started doing this presentation, I guess I have to stand close to the microphone here, there was a bit of a scheduling conflict, which is why we're doing a combined presentation. But it worked out well because I reviewed the sort of the pathophysiology, symptoms, et cetera, of post-dural puncture headache, and also some of the current treatment options. And then Alan focused on the spinopalatine block in particular, which he had an opportunity to participate in. So that's great. So start off here. So our major objectives, so first off, we want to review the signs and risk factors for post-dural puncture headaches. We want to review established treatment options. Examine treatment options and then discuss the new potential treatment option in spinopalatine block.
Yeah, so this was a case that I saw at Vancouver General Hospital as an R2, well, 2 months ago now. So, well, first of all, this is the patient I did not cause an epidural puncture headache. Just want to mention that. So this is a 52-year-old female who underwent a laparotomy for a total colectomy for cancer. Her past medical history is simple: hypertension, dyslipidemia. Pre-induction, the anesthesiologist tried to get an epidural in the thoracic area. Fortunately, multiple attempts failed and got 2 dural punctures, and thus he or she abandoned the epidural technique. So I joined the perioperative pain service, and then me and the attending, we went to see this lady the next day after the procedure. Unfortunately, she was complaining about this 7 to 8 out of 10 intolerable headache that was localized to the occiput, radiating down to the neck, worse when sitting up, a little bit better when supine. She was on the IV PCA hydromorph for her pain management, but she tried it for her headache as well, and unfortunately didn't go away with that. Her vital signs were within normal range and stable, with a temperature of 36.6 degrees Celsius.
Okay, so now that we have a little bit of history to go on, so we're just going to do an overview of post-dural puncture headache. So as you know, it may occur after intentional dural puncture, such as with a spinal needle, or unintentional dural puncture with a epidural needle or other non-spinal needle. For example, the syringe you use to place local with, etc. So the often quoted risk from all the resources we reviewed is 1.5% with unintentional dural puncture with any epidural needle. And then if they are part of that 1.5%, half of them will experience a post-dural puncture headache. This compares to a 25-gauge Whittaker spinal needle, where the risk of post-dural puncture headache is 1.5 to 2%, so significantly lower. We reviewed a variety of other spinal needles. This is a table provided by Chestnut. Basically, it shows some of the other needles that are less commonly used. However, you can see the variety of gauges available for Whittaker and a slightly increased risk with a higher gauge, but not by much. So it's important to remember when assessing these patients that not every headache after vaginal delivery or C-section is a post-dural puncture headache. There's a very broad differential. And it's important to consider these other options because a few of them, as you can see, can have some pretty serious complications. So one way to distinguish between post-dural puncture headache and other headaches is symptoms, of course. So headache pain is typically in the frontal and occipital regions, often radiates to the neck, typically starts within 1 to 2 days, but 95% of people will lose symptoms in 1 week. And for some women, it's a little bit of an inconvenience, and for other women, it's extremely incapacitating and can lead to chronic headache. So the International Classification of Headaches has created a little bit of a diagnostic criteria. So the symptoms must worsen within 15 minutes of moving into an upright position, must improve within 15 minutes of moving into a supine position, and must have at least one of the following: nausea, vomiting, neck stiffness, photophobia, tinnitus, and hearing impairment. Other rare symptoms that were reported in case reports were seizures, bilateral forearm pain, abdominal pain, and diarrhea. And all those symptoms cleared with an epidural blood patch in those case reports. Yeah, strange, hey? Anyways, so as you all know, it's a clinical diagnosis. However, there is some options for imaging. So we saw a few papers here. So the first paper was done by Bakshi et al. In 1999, and it shows abnormal dural meningeal enhancement and expansion of the superior sagittal sinus, which is the arrow there. So those are a few of the findings. And then another study performed by Corbonis et al. In 2010 shows an MRI brain 5 days following epidural catheter placement and post-dural puncture headache symptoms. So the first image shows, as you can see, a bit of sagging of the tonsils and the cerebellum there. And then also the second one shows enhancement of the meninges. The third one, they said a little bit of subdural fluid collection, and then the fourth one was parenchymal enhancement. So those are some findings you may see if you're uncertain of a diagnosis and an MRI ends up being ordered. So the pathophysiology, so first off, of course, there's the dural puncture, unintentional or intentional, and then through that hole, CSF leaks. And because of this, there may be a decrease in CSF pressure. And with this decrease in pressure, there could be traction on a variety of structures, including cranial nerves. And then, as you know, the brain tries to compensate for the different pressures inside, so it may venodilate and increase cerebral blood flow that way. And both of those mechanisms are thought to produce headache. Now, this is theoretical at this point, based on our best knowledge. There may be other mechanisms at play that we're not completely aware of yet. So a variety of risk factors. So age. Age is a major risk factor for a variety of reasons, including an older person's dura may be less likely to gape and produce a hole, or there may be adhesions which block flow. Female gender, vaginal delivery, previous history of post-dural puncture headache, multiple dural punctures. They say that cutting is more likely to produce post-dural puncture headache than pencil point needles. There's a study performed by Strupp et al. In 2001. And so you can see that image there. The top needle is a Sprott needle, so it's pencil point needle. And you can see how in the corresponding side there, when it traverses the dura and produces a hole, it kind of closes back up again. It's less traumatic. And then the needle below is the Quincke needle, which is a cutting needle. And you can see that the hole that it produces is more patent. And then there's uncertainty with regards to obese patients. Some studies say that it's increased risk, and other studies say that it's decreased risk. There's more risk factors. So the dura is a complex structure. So initially, when they figured out that perhaps if you place it parallel to the long axis of the spine, that you'd have a decreased risk of post-dural puncture headache. So initially, they thought it was that you were separating the dural fibers and kind of just passing through and creating less trauma. But other studies have shown that the dura is actually very cross-linked and interlinked. So they're not exactly sure why this decreases risk, but it does. So they suggest parallel orientation if you want to decrease your risk. However, some staff don't like the idea of having to revert back to perpendicular rotation to insert the catheter. Theoretically, more risk with median versus paramedian. So when you create a hole in the paramedian, in the median approach, it's kind of just a hole, but when you create it in the paramedian approach, they theorize that there's a flap that sort of forms and therefore closes off potential CSF leakage. Lack of adequate prep dry time. If you accidentally track prep into the space, it could cause some issues. Glucose-containing solutions and loss of resistance to air or saline is equivocal according to a number of studies. And there's no increased risk with CSE. So there are a number of complications. So of course they can range from, again, mild inconvenience to ladies may not be able to take care of their children if this is an obstetrical patient. They may have increased length of hospital stay by almost a full day. They have increased emergency room visits, and 40% of those ladies visit twice. They may have issues with hearing loss and vision loss, and they may develop more serious complications like subdural hematoma and dural sinus thrombosis. So PDPH prevention. So what I mean by prevention is when you know you've caused a dural puncture, but the person has not yet experienced symptoms. So as you know, it takes about 24 to 48 hours for symptom onset, oftentimes. And so prevention is that time in between. So far they've trialed on all the interventions effectively that they currently use for treatment, and they've found that no intervention after dural puncture but before development of symptoms has any benefit. So this includes bed rest, overhydration, caffeine, ACTH, epidural morphine. In fact, you can have increased risk with that, intrathecal catheters, saline bolus and infusions, prophylactic epidural blood patch, and dextran patches. So now moving on to treatment. So this is patients who have had a dural puncture and then experienced symptoms. So there's two categories, non-pharmacological and pharmacological treatment. So non-pharm, extremely important in this patient population. So psychological support, supine posture will relieve symptoms but will not create a huge shorten of duration of the symptoms. And then they say avoid dehydration because, as you know, you need fluid to produce CSF, and you need that for feeding a baby if it's an obstetrical patient. But they found that there's no benefit from overhydration. So there was a study in particular which discussed 3 liters versus 1.5 liters in patients who've experienced post-dural puncture headache, and they found no difference. So other treatment options, so moving on to pharmacological treatment options. So they found that there's transient benefit from caffeine and epidural saline boluses / infusions. So the one study that suggested caffeine, there was an RCT performed by Kamen et al. There was 40 postpartum women who received one-time caffeine versus placebo, and they showed decreased headache scores on the visual analog scale. So the suggested dose in chestnut is a maximum of 600 milligrams at 24 hours, divided in 300 milligram doses at least 8 hours apart. The next option is epidural saline or bolus infusion. The thought there is that if you restore the CSF volume and pressure, that you'll be able to relieve symptoms. And in some people, this does work as a bolus or as an infusion. They say that they need increased studies with regards to this for which one would be better and for how long the treatment would work. Now, with regards to the following, sumatriptan, ACTH administration, pregabalin, methylgronabine, gabapentin, hydrocortisone, epidural morphine, they say that they still require further studies. Some of them show promise, but there's not enough data and safety data with regards to them. So, of course, the gold standard of treatment is the epidural blood patch. Interestingly enough, Chestnut states that there's minimal RCT studies with regards to efficacy on this. However, the variety of papers quoted show about 33% to 75% efficacy with the first patch, and then that increases with the second patch. There was studies performed to try to determine the exact amount of blood to inject. According to Chestnut, the best evidence available is a multi-center trial by Peach et al. In 2011. It randomized 120 women after unintentional dural puncture with a 16 to 18 gauge 2E needle, and they either received 15 mLs, 20 mLs, or 30 mLs in the epidural space of blood. And they showed that the 20 ml bolus had the highest relief value at 73% compared to 61 and 67% for the other two. So that is currently their suggestion. The mechanism for action is unclear, so potentially it's because you're restoring volume by plugging up the hole, but the symptoms are relieved quite rapidly, so they're thinking perhaps there's a vasoconstrictor effect or an inflammatory effect at the site which causes sealing of the hole. And again, optimal timing is unclear. You definitely want to wait until the epidural is regressed, but you also want to wait another 24 to 48 hours, which is suggested currently. So this is MRI images of pre-epidural blood patch and post. So the first image there, which shows the arrows, that's basically where the CSF has been leaking from an unintentional dural puncture. The 3 corresponds to the vertebral body. And then the second image, after 20 mL of autologous blood was injected, you can see that there is a tamponading effect of the dura. And perhaps that's contributing to an increase in pressure and CSF volume. But as you can see there, if there's too much blood injected, you could cause some side effects. So complications, so kind of leading in from that picture. So back pain is the most common. 35% of people will experience back pain. Some people will have that as persistent, about 16% for a number of months or even longer afterwards. Lumbovertebral syndrome, so pain in the lower back, pain in the legs, radicular symptoms, case reports of scarring and permanent injury. With regards to infectious and hematologic, if the patient has a bloodborne infection and you potentially seed the dural space, that's a risk of meningitis and other infections. And they also did studies with patients with malignancies, whether or not it's a potential to seed the space there. And so far it's suggested that if a patient does have a malignancy, not to perform an epidural blood patch on them. So there are alternatives, but they're not really commonly used because, again, there's not enough studies and safety data on them. So this includes dextrin/gelatin patches, fibrin sealant patches, and there have been case reports of surgical closure of dural holes, which have relieved symptoms. That's extremely rare. So now we'll just go on to Alan's case and continue from there.
So thanks, Kat. So going back to the case, so we tried all the typical things that Kat suggested in her presentation. So first thing we try to do is try to hydrate her with IV fluids. We use Ringer's lactate at the time. And as Kat suggested, don't overhydrate them because unfortunately, we actually had to stop the infusion because she started becoming overloaded when we heard crackles at the bases of her lungs. So afterwards, we also try to control lac infusion as well. We use 90 milligrams in a 1,000 milliliter normal saline bag and just infuse that slowly over 24 hours. Unfortunately, we also had to stop that too because for some strange reason, she became extremely anxious on it every time the infusion was started. When they stopped it, she got better. We started again. She got more anxious again. So we had to stop that as well. We suggested that getting the patient to lie flat to help relieve her symptoms, which did slightly work, but this patient, unfortunately, was saying, oh, it gets better, but I don't feel comfortable lying on my back. I want to be sitting up a little bit, even though I get the headache. So we were like scratching our heads on that part as well. And the patient refused the epidural blood patch. And honestly, I don't think we were too keen to do it either, since she already had 2 dural punctures before. So this is where we decided that we should consider doing a sphenopalatine block. So what the sphenopalatine block does is, as its name suggests, it blocks the sphenopalatine ganglion. The sphenopalatine ganglion is situated in the posterior end of the nasopharynx. There's 2 on either end. There's multiple inputs going into it, such as the maxillary nerve, parasympathetic, as well as sympathetic nervous system nerves. And it has lots of outputs as well, innervating the nasopharynx. The key feature about this area, however, is the fact that the mucosa is only 1 to 2 millimeters thick. Thus, this leads it to be amenable to a transmucosal lidocaine block. So this sphenopalatine ganglion block is not new to the ENT world. They used it multiple times in many different types of headaches. Dr. Robbins, in this 2015 review article, did an excellent job reviewing the evidence behind it for headaches, as well as the physiology, as well as what sort of medications they've used. So the best evidence in the ENT world is for cluster headaches. It's not only proven to stop the cluster headaches, but it also reduces the recurrence of cluster headaches. Migraines is also another one for those which are refractory to sumatriptans or other treatment options. But the evidence is a little bit more mixed, with some showing benefit while others showing there's no benefit. The first article to suggest using sphenopalatine block for PDPH is by Dr. Cohen in 2000. He suggested he didn't seem to actually have done it yet. So what he did was he used amla cream on cotton applicators in each nostril for 10 minutes. And they say they use this technique for tension or migraines for patients who were undergoing labor or were in postpartum period. Then they said that none of their patients had side effects, and that they're considering using this technique for mild to moderate posterior puncture headache. So it sounds like Dr. Cohen may be trying to jump the gun, trying to claim the first one at using this technique. There is actually a feasible reason why this could work. So what you do is you block the sphenopalatine ganglion. That's my representation of a cotton tip applicator. And then what happens by blocking that, you then inhibit the ganglion's parasympathetic system. By inhibiting that, you then inhibit the meningeal vasodilation, which is theorized, as Kat suggested, to relieve the headache. So it's not an unreasonable thing to try out. The nice thing about it, it's really simple to do. No needles, no complicated machinery. What you need is really just cotton tip applicators, hollow bore if possible, as well as well as lidocaine 2 to 4% viscous or solution, or 5% from what I've seen in some other places. So the technique is also very simple. What you do is you get the cotton tip applicators, soak them in lidocaine, either the viscous or the solution, and while they're soaking, you get the patient to lie supine and then go into a sniffing position, just so it's easier to direct it downwards. Afterwards, you take out the cotton tip applicators, you put the cotton tip at the nair, and then using just one finger, you just slowly advance it until you reach an end point, which should be the posterior end of the nasopharynx. From some YouTube videos I watched, and yes, I use YouTube, they suggest actually going posterior, medial, as well as a little bit superior, just to better place the cotton tip where the sphenopalatine ganglion should be. And afterwards, you just leave it there, actually. You just leave it for about 10 to 20 minutes in some studies. Some studies suggested leave for 40 minutes, but if you have the hollow tip bore, you can slowly drip lidocaine through to continuously infuse lidocaine in that area. And afterwards, you just remove the cotton tip applicators. So this is one of the YouTube videos that I found, which I found illustrates this thing really well. While he's doing that, so this is a video I've taped by the patient's husband because she was having like chronic migraines, refractory medications, and he's just videotaping it so that he can do it for his wife as well. And yeah, so after that, there's nothing much else to see. So I guess the key thing why I want to show that video is because one, it's really easy to do. Like they're teaching patients how to do that themselves at home. Second thing is that it's you don't need much equipment, just the two things, the medication and the cotton tip applicators. And so those are really the two key points about it. However, like any procedure, there can be side effects which we must warn patients about. One of them is the mild discomfort from the insertion of the cotton tip applicators. But honestly, if you just insert it slowly, then patients often tolerate it very well, as you can see in that video. The second thing is there may be a little bit of burning sensation from the lidocaine itself, as well as the lidocaine's unpleasant taste going down the back of the throat. The fourth thing, the numbness at the back of the throat, was mentioned by Dr. Robbins in his review, saying that since the lidocaine is numbing the back of the throat as well, sometimes they get that kind of gagging or that ball sensation in the back of their throat. And it's important to counsel patients not to eat or drink anything because they could be at risk of not having that gag reflex and aspirating. As well, hypotension, nausea, and epistaxis from the insertion is also possible side effects. Good question. So at least in my patient, we did it on both sides. You could do one side and then do the other side at the same time. I guess why you could do just one side is more for comfort, since they can probably still breathe through the other nose, while versus two, where you get more efficiency, because you then have to wait around, put it in again. No, it's not. That's correct. So you can't just do one side. You got to do both sides. It's just up to you whether you want to do one side, then the other side, or both at the same time. Contraindications, relatively simple, either uncooperative patient or local anesthetic allergy. So what is the evidence or the efficacy behind this? So Dr. Cohen came back in 2009 with this paper of his case series. So he had 13 patients with moderate to severe post-dural puncture headaches. He then used lidocaine 4% on cognitive applicators daily up to 1 week. He either did himself through the pain clinic or he actually taught the patients how to do it themselves at home. And what he found was that 11 out of 13 patients had immediate to complete relief, while 2 out of the patients still required to go on to get an epidural blood patch. So 11 out of 13 is a very good result. Exactly, because the duration of the sphenopalatine block doesn't last as long, which I'll talk about soon. And so fairly good results, especially if you want to consider the alternative of an epidural blood patch. However, we're not sure how many patients would have ended up with an epidural blood patch anyway. Dr. Cohen then did another case series in 2014. This time he got 32 patients with post-dural puncture headaches secondary to an accidental dural puncture from a 17-gauge epidural needle. Then he used lidocaine 5% this time in each nostril for about 10 minutes. And then...
Correct.
That's right, these are case series.
These are just case reports.
Yes,
Yeah.
case
We'll
reports.
get to that.
So, and then in his case series, he said 69% of patients were saved from having to undergo the invasive epidural blood patch in favor of a safer, more cost-effective, and less invasive technique. So fairly bold statements, but again, illustrating that sphenopalatine block may be a feasible option for PDPH. So different authors this time. Another case series in the emergency department this time by Dr. Kent and Dr. Mahaffey in 2015. They had 3 patients come in through the emergency department for post-dural puncture headaches. 2 of these patients have post-dural puncture headaches because they had a lumbar puncture the previous day to rule out meningitis. And I'm assuming it wasn't meningitis. And the 3rd patient came in because she had a pseudotumor cerebri, and they did a lumbar puncture to do the opening pressures. So what they did for these 3 patients is they did 2% viscous lidocaine 10 minutes, removed these cotton applicators, put more viscous lidocaine, and then put them back in for a total of 30 minutes of viscous lidocaine treatment. And what they found was that pre-treatment, these patients had fairly moderate to severe headaches pre-treatment, 8 to 9 out of 10. And then immediately post-treatment, their headaches went down to 1 out of 10 to 4 out of 10. These patients were discharged home, and they did a telephone follow-up, which they then found that patients said the headaches returned about 10 to 12 hours afterwards. And about 24 hours after, their headaches were about 4 to 8 out of 10. 2 out of 3, however, still required an epidural blood patch by the end of it. So this study, to me, suggested that again, it's feasible, it's easy to do. Like emergency departments, they're fast-paced, they have lots of patients, but they even have the time to be able to do this. But at the same time, though, it really illustrates the time duration of the sphenopalatine block, which could be its biggest disadvantage, that it doesn't last days and days, only lasts hours, hence why previous case studies needed the daily treatment for up to a week or until the headache resolves. Sorry. So another paper that Dr. Hoskin kindly forwarded to us was published in Medscape. It's about a poster presentation at the American Academy for Pain Medicine in 2016. This time, this is more of a randomized trial and the only one that I'm aware of. They had 72 patients with no prior primary headache history who then came in with post-dural puncture headaches from an epidural needle. So they split these 72 patients into 2 groups. Group 1, with 33 patients, had the lidocaine treatment with lidocaine 4%, dripped down the hollow bore applicators of 0.5 to 1.5 milliliters on each side, but they always had the option of an epidural blood patch if the patient should choose to get that. Then group 2 went straight from the epidural blood patch. And what they found was, as for regarding to recovery from headache, at 30 minutes post-treatment, group 1, or the group with the lidocaine treatment, 54.5% of these patients had relief, while compared to group 2, only 20.5% of patients had relief. While at 60 minutes post-treatment, group 1 had 63.6% of patients who had relief versus the epidural blood patch, which is only 30.7. So it shows that sphenopalatine ganglion block can have fairly immediate effects compared to the epidural blood patch. And they found that there was a statistical significance as well. Furthermore, this is just in their words, I didn't see their data on this. At 24 to 48 hours and at 1 week, the nerve block was as effective as a blood patch. So fairly bold statements again, but suggesting that we could use this as an alternative.
Kind of odd on the face of it. I mean, I don't think I've ever done a blood patch where the patient didn't have relief after the blood patch. And to say, 20, 30% have relief after a blood patch in their study, something seems a little amiss about that.
Likewise. Yeah, I thought that part was a little bit weird. And also the fact that it took 60 minutes for, like, on the other side, the lidocaine to work, when most of the other studies should suggest it's a fairly immediate effect. That's why it's still a study that I want to present to the group to cover, just to be as comprehensive as possible, exactly holistic. But yeah, this data could be a little bit suspect, and as far as I'm aware, it hasn't been published yet. So
yeah, it was presented in February 2016, so perhaps they're waiting on publishment. But we will cover that there's a new RCT, I believe, that's going on currently in Canada. So
which I'll mention. So going back to the case, so I watched the YouTube video the night before, and then went to the patient and said, yeah, this has been done before. And the patient consented to the sphenopalatine block. So what we did was 2 cotton applicators with 2% lidocaine. We searched the AA's office. Wouldn't say we left a mess there, but we really couldn't find any higher concentration at VGH, unfortunately. Then we went up to the patients on the ward, and then we applied the cotton applicators for 5 minutes. Unfortunately, as you guys may have heard, she was a little bit on the anxious side. So while we're aiming for 10 minutes, she only tolerated for 5 minutes, and we had to take them out afterwards. However, her headache did go down from 8 out of 10 down to 6 out of 10 when she went from supine to sitting up, which is suggestive that she is better to tolerate her headache now, and that there's some efficacy around the sphenopalatine ganglion block. Unfortunately, when I followed up on her about a couple hours later, the headache returned again back in full force. So, reflecting back on this case, things that I would have tried to change, I guess, is try to use a higher concentration lidocaine, either request from pharmacy or try to look harder, I guess, for a higher concentration, or viscous lidocaine potentially. Maybe reapply the lidocaine applicators after she asked him to get them removed. Like ask her if she can tolerate it again, or consider doing just one side first, then the other side, and see if that's better for her. I'm sorry? Okay, yeah. And there was a suggestion of cocaine. That'll be an interesting case study. Okay, maybe I'll do that for my research project. I know. Let's see if I get that through ethics. I'll let you guys know. We also fortunately have some staff anecdotes as well. Dr. Barry Thornhill, who's currently doing his obstetrics fellowship right now, we emailed him asking for his opinion, and he emailed back saying that he so far finds that the results have been fairly encouraging for this, and in fact, the University of Toronto is going to be doing a large prospective trial on this treatment. Things that he suggested that this treatment could be beneficial for includes people who just have mild to moderate PDPH, people who are Jehovah's Witnesses, people who do not want the epidural blood patch like our patient or are contraindicated to it, and people who have uncertain diagnosis of PDPH. Dr. Hoskin also attempted this before back in May 2016, kindly shared his experiences with us. His experience is that he had this 35-year-old prima gravida female who unfortunately had a dural puncture on the first attempt of a labor epidural. Second attempt, he managed to get the epidural in and got good block. Baby was fine, patient was fine, until about maybe 24 hours later when she presented with classic symptoms of PDPH with the headache as well as auditory changes. POA was consulted on this
Just to clarify, Dr. Hoskin did not perform the epidural.
Oh, sorry.
He was the POA who...
My apologies, Dr. Hoskin. So he's the one who saved the day then. He discussed treatment options, including conservative management versus analgesics versus the epidural blood patch, and the patient decided to try conservative management first. However, by the next day, the patient wasn't tolerating conservative management, and patient requested intervention. So after further discussion, Dr. Hoskins attempted the sphenopalatine block as well. What he wrote to us is that he brought the patient to PACU for monitoring, got the hollow tip applicators inserted to each nair, and then dripped 4% lidocaine, 1.5 milliliters each in each nair. And then he did it over 5 minutes, and then left them in place for 30 minutes, then had them removed. Excuse me. And then fairly soon after, the patient's headache came down from 8 out of 10 down to 3 out of 10 on standing, and was tolerating very well. However, within about 24 hours, the headache did return back to about 7 out of 10, and he repeated it again back on the ward and brought the headache back down again, but this time it only lasted for maybe a couple more hours before the headache returned, and since the patient wanted to go home, he went on to get the epidural blood patch. So I guess, we would like to open the floor to everyone else who's had experience with this block or other possible treatments for PDPH.
Has there been any consideration, or you read anything about using a different local anesthetic like bupivacaine for these types of blocks, and you might get a longer duration?
That's a good question. At least when I went through that review for the ENT one, like the ENT review on sphenopalatine block, they say they have maybe 1 or 2 studies with bupivacaine, but it didn't show to be any better compared to the lidocaine itself.
Is there anything written that, I'm not sure how common it is. I've always understood that people can get a sixth cranial nerve palsy from the brain sagging. And in a sense, I've always then thought of it as a blood patch as been sort of helpful in preventing a complication that way. I don't know how long that nerve palsy will last if they get it or whatever. Is there any potential issue that you're just kind of masking symptoms, keeping the patient comfortable for a couple of days, and they're more likely to get complications related to the post-dural puncture issue?
That's an interesting question. So when I was, I might have to go back a few slides here, but when I was reading about epidural blood patches and the cranial nerve palsy, they said that despite having the epidural blood patch, not oftentimes will they actually experience relief symptoms from that particular palsy. So it's kind of an interesting thing. I don't know if you came across anything where it masks symptoms of more serious issues, but...
Not that I'm aware of.
Yeah.
I was at a conference in Toronto 2 years ago, and it probably doesn't happen very often because it was just a case report on a poster, but it was somebody who developed symptoms and then kept trying to treat it, but her symptoms got worse and worse and worse until she ended up having a really decreased level of consciousness. So she got scanned, and the thought was that the traction, she ended up developing a big stroke. So she ended up I don't know if she died or not, but it was a massive stroke, and there was a big picture of the head CT. So it was basically, epidural puncture is not always a benign phenomenon. So to follow up the patients frequently and not to miss something.
Is this a young patient out of interest, or?
Yeah, it was an obstetrical patient. It was
Wow.
at SOAP in Toronto. I was in Toronto at the time, so I just showed up for one day of the conference, walked around the poster session, and there was this big head CT with a big So I took a picture of it, but my phone got stolen, so I don't have that picture.
It's got some other guy who's presenting it to his friends.
I think the thing that I find most interesting, because I'm very reluctant to do blood patches, and your list of complications, chronic back pain in what, 17% of patients, I think that's a very telling figure. I'm even more reluctant now than I was.
It didn't say chronic back pain in 17, it said back pain in 17%,
Back pain
didn't
in
it?
35%
Or-
of patients, and then I
Some
think
guys will
it's
do it at the
60%
width of the thing. I think
Oh,
it's
really?
not I think it's an invasive procedure, and I'm reluctant to do it.
Well, that is causing an epidural hematoma.
Yeah.
And especially depending on the volume
Yeah,
of
and
blood
if
you
you've
use,
got
which
it-
we also wanted to poll the audience about.
As much as you can use before they start to get back pain or neck pain.
Right, exactly, that was also.
Maybe you've gone too far.
As much as
Some years ago, there was emphasis on cautechoin or arachnoiditis association.
Correct, yeah.
Which is a horrible complication.
That was also described.
That's partly what has affected my thinking.
It's interesting, like, I mean, it seems like a really good idea, especially if you're uncertain of the diagnosis. If you do that and you relieve symptoms, well, then maybe that's telling.
Well, not necessarily.
No,
It
because
could be a
any-
migraine or something
People
else.
have headaches all the time.
Yeah.
But
Right,
related to
so-
like the sphenopalatine ganglion.
Well, no, it's used in treatment for migraines, which is also thought to be due to vasodilation of the meningeal vessels, so hence why that's why it suggests this for uncertainty, because it's at least a relatively safe procedure without exposing the patient to bad complications.
Is there any downside to teaching them to do that themselves and sending them home with viscous lidocaine?
That's what the YouTube is.
No, I don't think so. And with the number of YouTube videos, I don't think so.
Did you see any hypotension, or has anyone seen any significant hypotension that would
Starbucks straw.
make you concerned?
Well, case series didn't report any hypotension, and I have my N of 1 do not have hypotension, so unfortunately I don't have enough experience to
And
be able
Dr.
to
Haas.
say.
Yeah, I mean, if they did, it would mostly be vasovagal anyway, right? I mean,
And they'd be lying down.
yeah, why would they? I mean, it's.
They just list it.
Suck it up, princess.
I mean, this seems like a good treatment just for headache, NYD, postpartum or something. Like you don't know what it is. Like you can just do it and be like, well, if you want to try something different, we can do this thing and it'll probably work.
It's 6 o'clock at night and you don't want to do it before you go home.
You wouldn't want to use it on a basal skull fracture headache.
Well, you just have to not
get someone it doesn't take much training to do one of those, and then they can come in the next day if they still have a headache and get a blood patch and they're more controlled conditions where you're not running other people.
So we have a lot of sick calls for migraines too. So
home visits.
bring them in, we'll block them, we can come out and look after
It was interesting in that one study, the failure rate of blood patches was even, well, I would say quite enormous. I must say, I certainly don't think mine's 100% successful immediately, but I would have thought they were better. But is it because we're not following them up?
Well,
Because we do them, they get great relief, and then we send them off.
but I mean, I agree. I mean,
And they don't come back, maybe they go, oh, I don't want to see that person again, but.
I don't think so. I mean, I would agree with 100%. I mean, I've never had a single patient come back after an epidural blood patch and complain of a headache.
Yeah, but
Yeah,
statistically,
but
the
we
success
don't
rate is
always
only
follow up
70%.
And even studies say 33 to 70%, so there's definitely studies that have been done without regards to the sphenopalatine block that have shown that it's not.
Who are followed up for a period of time. Maybe that's the problem, is we're not following up our post-dural puncture patients.
Well, I mean, I was going to say, the one thing, the 7-day treatment with your block, I mean, if you left the patient with a headache for 7 days,
would go
they
away.
probably would get better
Yeah,
anyway,
95%
right?
will go away.
So I think that
Helps
might
them
be the other
tolerate
issue,
it.
right, is that you do
Yeah,
the you do the blood patch, they get some relief, they go home,
Suck it
2 or
up a
3 days
bit.
later, they just get better on their own and you never hear about it.
Or they get a mild headache, I think that's better.
Yeah, perhaps.
Exactly. So all these treatments, I believe, is just more of a temporary measure to try to get them through that self-limit time duration of the PDPH. So that's why sphenopalatine block, theoretically, you just teach them, tell them, just keep doing it until your headache is gone. Of course, you want to tell them, don't keep doing it every day, or else you get lidocaine toxicity, probably. But yeah, that's why that's the case series for only 1 week, because we're hoping that by the end of that 1 week, the patient is relieved.
Huh.
Also, we were wondering what volumes. Oh, okay. So Dr. Rams injects volumes until the symptoms appear.
Well, either that or the biggest problem actually is actually drawing the blood.
Okay.
Because you know, generally you're trying to do this by yourself. You rarely have a lot of help, so you're kind of going back and forth, and you end up losing the vein, and
okay.
and then you're kind of whatever volume you have is what you use.
They say until the patient says they have a feeling of fullness in their back,
Yeah.
Okay.
which is 15 to 20 minutes.
That's what it usually corresponds to. Okay.
Yeah,
I'm curious, like, how often do we do epidural blood patches here at RCH?
I do it on my own.
More in the summer. I don't know why, but it seems that. Yes. Well, I'm thinking of, yeah, or, yeah, early residency.
Oh.
But, I don't know, I mean, I've already done 10 of my time here, it's not that common, right? I mean, in that.
Well, I don't think I've only caused maybe one in my entire career, but I must have done about 20 of them.
Yeah. I'm not talking about causing them.
Nailing out his colleagues.
That's funny, Doug really has the same statistic.
The only two I've done it in the same week, so I think it's come and go.
Yeah, no, yeah, well, that's interesting, I don't know.
Yeah, it'll be interesting to see what this study out of
Well,
Toronto shows.
Should we put in a clinical guideline? A protocol as to how we're going to manage PDPH?
I think that's a good idea, which doesn't say you have to follow every step of the guideline, but it gives you
a
options.
suggested
Yeah.
Collect that.
approach.
The other thing you haven't addressed actually is, in fact, the more common epidural blood patch I've done is when the neurologist has phoned
Yeah.
said they have a low pressure headache, we can do a blood patch because that's been shown to work.
Yeah.
That's a bit of a pain, but the neurologist has made the assessment that he doesn't have something else going on, so I feel reasonably comfortable doing it, but
Yeah, we get that a lot.
I don't know whether they work though.
Yeah.
And then the radiologist who has gone into some kind of paravertebral cyst that's actually CSF. We had one guy who came back for 3 blood patches and eventually had to come back to have it sewn up.
Yeah.
Really?
Yep.
That's that.
He had a Tarlov cyst that they were doing a nerve block under radiological guidance, and they'd gone through the cyst and it just wouldn't heal. And he'd get relief from the blood patch, but it just persisted.
Which raises another scenario, the patient who has a surgical CSF leak.
Yeah.
So,
But they
Yeah.
put blood in there.
Well, I mean, the surgeons do follow those up. Like I did one with Dr. Chan like last week, and the WC patient he's had come back, comes
That's
back
why.
every year to get it kind of.
yeah, just make a bigger hole each time.
Yeah, exactly. I mean, maybe, there may be some secondary gain to that.
I mean, well, would a blood patch work in that patient though, really?
Well, probably not.
Yeah.
Well,
Yeah, well,
I mean,
You did how many? 3 blood patches
3
on
blood
one
patches
patient?
on one
I mean, so how many people would actually go and do a second blood patch on somebody?
Maybe
Maybe a second, I don't know about a third.
I'd be hard pressed, you know, with the
I guess
success
his
rate.
option was he got relief, and then it was like, I go back for surgery, or I have another one. And we did another one, and I said, that's it.
Well, the study shows 70% first,
33 to
90% for the second, and then what do you do? So I think if you do one and it fails, or it is incomplete, that a second one seems reasonable, but I agree with John, a third maybe is except for the special situation.
It would actually be, like it would be something good to follow up on if we get, that might be a good summer student thing or whatever, if we keep a list of who came in complaining of a posterior puncture headache, and they get called up on the next summer saying, hey, how long had your headache lasted? Or, I mean, it's nicer if it's at the time, but.
Well, we should have a registry, and maybe POA could do the follow-ups or something like that. That's a perfect perioperative.
Yeah, just.
Well, it's not like there's that many of them to call.
Or rover. Just
They
a
did
phone
the-
call.
they did
That's
the
not a
blocks,
lot of
yeah.
extra work. Yeah. Maybe we should have a registry. Let's do that.
Okay, Peter, or sorry, okay, Richard. Have at it. Don't drop it back in my lap.
Somebody do a website for us. Oh, put it on our website. We never have a website.
Where is our website?
Yeah, where is our website?
There.
Make it so.
The project, yeah.
All right, good job.
Thank you.
Who's got the sign-in sheet?